Okay, welcome to the quarterly GTI webinar. I'm Dr. John Stone, professor of medicine at Harvard Medical School and the Edward A. Fox Chair in Medicine at Massachusetts General Hospital. It's a great pleasure to have you with us today. So let's get going with the agenda. I'll talk about data capture for dimwits. People think that steroid toxicity is complicated, and it is to a certain extent, but the GTI has really made things simple by focusing on the important elements of steroid toxicity that are likely to change. And the data capture really is quite straightforward no matter how you use the GTI. We will then have a demo of the GTI in action. Following that, I'll talk a little bit about the construct validity of the GTI and the minimum clinically important difference of the GTI. And then we'll talk about incorporating the GTI into your work. So the GTI, by way of background, is a standardized, validated, and weighted instrument designed initially to be used as a clinical trial outcome measure. And indeed, that is now how it is being used in multiple clinical trials. It can also be used for real-world studies and in real-world practice as well, but it was designed originally for use in randomized double-blind placebo-controlled trials. Its purpose is to quantify change in steroid toxicity. It's not simply a laundry list of all the many dozens of adverse effects that can be associated with glucocorticoid use. Rather, it's designed to capture change between 2 points in time. Thus, it's really perfect for a clinical trial. It's a clinician-facing instrument, a ClinRO, although I do note that a PRO, a patient-recorded outcome measure, is also under development. The GTI and its pediatric counterpart, the PGTI, help prove that a new drug is both safe and effective. So the GTI and the PGTI were developed by a group of international subspecialty investigators, experts in their field, and pediatrics as well as dermatology and neurology and psychiatry, even maternal fetal medicine. So a great deal of expertise went into this. The whole process began way back in 2015. We used very rigorous and validated methods for developing this instrument. And the approach to this has been described in publications that I'll allude to. This patient's face, a young man whom I met a year or so ago, really embodies why this is important. He had been on steroids for high doses for 2 years before I met him. He had gained 75 pounds. He has the classic moon faces of a patient who's been on steroids for a long time. He has acne. He has hirsutism, unwanted hair on his face. And these are only the complications that we can see. This is a patient who could very well be his older sister, who has another disease that is treated typically with high doses of glucocorticoids. And you can see the faces of these two patients. The one on the right has ANCA-associated vasculitis. The one on the left has lupus, but they could have any of a number of other immune-mediated conditions that are treated with high doses of steroids. And what these two pictures underscore is that no matter what disease we are treating, at some point, we are really managing the same condition, and that is steroid toxicity. So what are the health domains that are covered by the GTI? These were selected on a very intentional basis. So they're simple, easy things: body mass index, height and weight, blood pressure, systolic and diastolic, easy to collect, always collected routinely anyway. Glucose metabolism and lipid metabolism as measured by the hemoglobin A1C and the LDL. Very simple blood tests, easy to perform, generally collected anyway in the context of a clinical trial at certain intervals. Infection, always obviously a very big potential issue in clinical trials and measured and scrutinized very carefully. These data are already collected. Bone mineral density can also be used as part of the GTI. The data are collected through a DEXA scan. This is optional as a domain to be measured in the GTI. And then finally, three things that require the clinician investigator to consider face-to-face with the patient. Is the patient weak? Does the patient have proximal muscle weakness? That's a very easy thing to test clinically. Does the patient have skin manifestations of steroid toxicity? Again, it's all there to be seen on a quick inspection of the patient. And finally, does the patient have elements of neuropsychiatric toxicity, insomnia, depression, and the like? These can be gleaned over the course of a simple conversation with the patient, as is conducted in the context of a clinical trial visit. I conducted 2 of those just this morning. Why were these domains selected out of all of the domains and elements of steroid toxicity? There are really 3 important reasons. First, these domains represent common steroid toxicities. These are not rare events. Many patients who were on steroids for a long time developed them. Second, they are important both to patients. They are terribly important to patients. Patients hate these things when they occur, and so do clinicians. These are the reasons we hate putting patients on high doses of steroids or moderate doses of steroids and leaving them there for a long time, even keeping them on low doses of steroids. This is why we hate these drugs. And then finally, these domains are likely to change. And of course, in a clinical trial, you want to be measuring something that can change. All of these will change. If the patient is on an effective steroid-sparing medication that allows them to take fewer milligrams of prednisone, then these scores will go down. If the patient fails their treatment regimen and has to get more steroids, then these domains will worsen over time. So data from these domains, each of which is weighted, it's one data set, and it provides 2 scores that help capture the nuances of steroid toxicity. And these scores are, number 1, the cumulative worsening score. You can understand from its name what this is. The cumulative worsening score records every single element of steroid toxicity that has occurred new since baseline until the follow-up GTI assessment, be that at an interval time or at the time of the primary endpoint. So that's the CWS, the cumulative worsening score. The second score, derived from these same data, is the aggregate improvement score, or AIS. The AIS is important because not all elements of steroid toxicity are irreversible. In fact, many of them are not. And we want to be able to demonstrate that a new effective steroid-sparing medication actually reduces steroid toxicity over time. So that's the aggregate improvement score, calculated from exactly the same data. The GTI scoring algorithm calculates this. The digital platform will do it automatically. All the investigator has to do is enter the data. So data capture for dimwits. As we all know, the weakest link in any clinical trial is the physician, the clinical investigator, who is always late filling out forms. We need to make it as easy as possible for the physician investigators, and that's how the GTI was designed. So this is a screenshot from the digital platform of the GTI, the different modules that are completed with the data. And though it might look daunting, it's not, because these things are entered automatically. The physician investigator doesn't even have to be present for these to happen. These are medication changes, vital signs, labs, bone mineral density, etc. Similarly, infections do not have to be recorded by the physician investigator at the time of the visit. The physician investigator needs to focus only on these 3 things. So I'm in a clinical trial room right now, and these are the 3 domains that we focus on when my next patient comes in. All of this other stuff has already been done. And I will ask the patient if he or she is weak. I will test that formally, examine the patient's skin to see if there are cutaneous manifestations of steroid toxicity. And I will talk with the patient, just as I'm talking with you now, to glean whether or not there is neuropsychiatric toxicity. So all of these elements really are very quantitative and simple to record, and we collect most of these data anyway. So let's take a look now at the GTI in action. This is the digital platform of the GTI. We have entered the patient's first 2 visits. So this is a hypothetical patient who was enrolled in a clinical trial that is, say, 1 year long. And the baseline visit, GTI visit 1, was completed about a year ago on the 25th of September 2020. Then the 6-month visit, at which the GTI was also reported, was done in February 19th, 2021. And today we are going to enter visit 3 to take you through how this is done. So we're in visit 3 right now on the 28th of September, 2021. That's today. On the right, you see that this is visit 3. And I showed you a screenshot of these earlier modules. So the first thing that one does when any clinical trial patient reaches the clinic is the study nurse updates the patient's medication. So this patient is say a 40-year-old patient with lupus who is in a trial for lupus nephritis. She is not a rookie when it comes to steroids. She's been on steroids for years before she got to this trial. And she had had some baseline steroid toxicity. This is where the aggregate improvement score comes in. So the patient is also on medications to help prevent or treat some steroid toxicity. So at baseline and at the last visit, the patient was on simvastatin and insulin and lisinopril. Now, the study coordinator will update these medications. Fortunately, now the patient has been able to reduce her simvastatin. She was on 80 milligrams a day. She's on 40 milligrams a day now. She's also been able to reduce her insulin requirement from 20 units a day to 10, and her blood pressure medication has stayed the same. She's on lisinopril 40. And no changes there. So then we're asked to confirm what the intention with these medications were. And with the simvastatin and the insulin, the intention was both to decrease them, and the blood pressure medication stays the same. Now, I add that one of the ways that one can use the GTI is through integration into a CRO's or a company's database and connection through APIs. That allows for the medications to be entered just once and makes it very, very smooth. Now we move to the vital signs. And again, this is all being done by the coordinator. You can see that the digital platform has recorded the patient's vital signs at trial entry. On the left, the patient is quite heavy with a BMI of 35.25 kilograms at baseline, and a little bit lighter on follow-up with a slight reduction in the BMI. Now, 1 year into the trial, the patient has been able to get off steroids completely and has been off steroids for some months because it was a fairly rapid steroid taper. And her BMI has had a remarkable reduction. Rather than weighing 86.1 kilograms, she now weighs 78.1 kilograms. And the digital platform calculates the BMI automatically, and her blood pressure has also improved dramatically. It's now 116/78. And now we go to entering the labs. So the labs might be done on the day of the visit. They might have even been done earlier. Maybe they're already back. This is something, again, the physician investigator doesn't need to deal with. They can be entered by the study nurse just once. So the patient's hemoglobin A1C, by virtue of the fact that she is not on steroids now for months, has continued to decline and is now 5.8. It's been a very dramatic improvement since the baseline visit of 6.8. And her LDL is about the same. It's 3.3 now. But she was able to reduce her simvastatin. Note that the patient had a diabetic neuropathy at baseline, and this is carried forward without the data entry person needing to do anything different. If one needs to be reminded of what the definition of diabetic neuropathy is, then that can be done here simply by rolling over the term. So this is now complete, and we now go to entering the bone mineral density. The patient has had an improvement in her bone mineral density now over the past 6 months. And at the femoral neck, the bone mineral density is up to 5.8 grams per centimeter squared. And at the lumbosacral spine, really dramatic improvement, 6.0 grams per centimeter squared. Again, this is just read right off of the DEXA report. It's very standard. And so the patient had osteonecrosis in her right hip at baseline. That's automatically carried forward by the digital platform. Fortunately, there are no other bone toxicities. So now the patient comes into the room where I am now, and the research nurse will put the patient on the table. I'll come into the room and ask some pointed questions about those specific domains that I mentioned. The first of these is steroid myopathy. Now, the digital platform shows in the upper left-hand corner that the patient did indeed have a moderate steroid myopathy at baseline. That is defined over on the right. Moderate steroid myopathy, this is a very standard definition, is a degree of weakness that does limit the patient functionally and decreases the patient's ability to perform ADLs. Very standard definition. But if investigators are not prompted to ask about this and examine for it, they'll miss it completely. Now, fortunately, the patient's steroid myopathy had improved at the previous visit, going to only minor, and now it has resolved. The patient no longer has steroid myopathy. So we move to the skin domain, and the patient's baseline and follow-up skin toxicities are shown here. There's a considerable amount of skin toxicity, and there is still some skin toxicity here in follow-up, but the hirsutism, which was present, is now resolved. So there's no hirsutism. The acne, which is moderate, is now minor. And there are pictures of these different toxicities. This is minor toxicity now. These pictures are included in the digital platform in order to ensure uniformity in scoring across investigators and across sites. The patient also had an improvement in the easy bruising, which is now only minor. It had been moderate. Okay, good. So the skin domain is now complete, and we move to the neuropsychiatric domain. Here, the patient still has some minor insomnia, but her depression has resolved. She is no longer depressed. She feels great. She hasn't seen a milligram of prednisone in 8 months now and is really feeling great. Final domain, which is weighted in the GTI, is the infection domain. The patient did have an infection, oral candidiasis, at the follow-up, at the 6-month follow-up visit, but over the past 6 months has had no additional infections. So all of the domains that are weighted are now complete, and then there is only a checklist that one runs through with the patient and in one's mind to make sure that not any other steroid toxicities have been overlooked. The patient had cataracts at baseline, and those have been carried forward. Those, of course, are damaged. Even if they are removed, they remain in the GTI, although they don't affect the overall score. The diabetic neuropathy is carried forward automatically by the digital platform. So now all of the data for the GTI have been entered, and we can get the scores. And these are the scores now at the primary endpoint. So the cumulative worsening score for this patient over the full course of the trial, there has been a slight increase in one element of steroid toxicity. That was the infection, the oral candidiasis that had occurred at the interim 6-month visit. But overall, the patient has had a remarkable decline in her steroid toxicity over the course of the trial. And that is reflected in the aggregate improvement score of minus 304. So wonderful improvement shown over the course of the trial. Now, on the left are all of the patients' different domain scores over the full course of the trial. And you can see all the negative numbers. Those represent improvements in steroid toxicity within those domains. So that was the GTI in action. And now I'm going to talk a little bit about the construct of validity. Does the GTI measure what it is intended to measure, change in steroid toxicity? And we have a lot of data around this now. So the data that I'm going to talk with you about come from a trial that was published in the New England Journal of Medicine in February, a trial of avacopan, a first-in-class complement inhibitor for the treatment of ANCA-associated vasculitis. So I'm going to show you the data related to the GTI that were collected in the context of that trial. Here is a quick overview of the trial design, which I have simplified here for the purpose of discussion, but there was randomization to either new drug or standard care, and the treatment period was 52 weeks, very much like the hypothetical patient that I just showed you who had lupus nephritis. The new drug regimen included the new drug and then a dummy prednisone taper. And then the standard of care group received a placebo for that new drug and a real prednisone taper starting at 60 milligrams a day and stopping after 20 weeks. The primary endpoint was measured at 6 months. The secondary endpoint, it was actually a second primary endpoint, but for discussion, I'm going to call it secondary endpoint, was measured at 52 weeks. And the GTI, which is actually the most important secondary outcome measure for efficacy, was measured both at 26 weeks, the time of the first primary endpoint, and at 13 weeks, quite early. This graph shows the cumulative steroid doses, actually the daily prednisone doses, the mean daily prednisone doses in the two treatment groups. Gray is the standard of care group, and maroon is the new treatment group. And here are the cumulative worsening scores for these two different treatment groups at both 13 weeks and at 26 weeks. And what one can see, again, the gray bar represents the standard of care, and the maroon bar represents the new drug, avacopan, cumulative worsening scores at 13 and 26 weeks. And what one can see is that as early as 13 weeks, and then maintained at 26 weeks, the new drug avacopan was associated with less new steroid toxicity than standard of care. And this was highly statistically significant. So the GTI reflected in this context the reduced glucocorticoid use that was called for by the protocol. The aggregate improvement score, or AIS, showed the same thing, again, at 13 weeks and at 26 weeks. I think it's remarkable how quickly the GTI changed. And that's very important. I think it speaks to the wisdom in choosing the domains of the GTI. Again, these differences between groups were highly statistically significant at both 13 and 26 weeks. So highly statistically significant, but is it clinically important? And here's where the MCID comes in, the minimum clinically important difference. The methodology for developing the MCID was described in the supplement to this paper shown here, which was published again in early 2021 in the European Respiratory Journal. But let me just say that the basis of the MCID, and this MCID was calculated based on patients who were used during the original development and validation of the GTI. The basis of the MCID is the standard error of measurement, which is the smallest change that reflects a true difference as opposed to simply measurement error. And there were 510 patient assessments scored by a total of 34 different clinicians who were part of this exercise. The MCID is determined in this validation study is 10 points. So what that means is that if there is a between group difference of greater than or equal to 10 points, then we interpret that as being clinically important. Similarly, if there is a change that exceeds 10 points or is equal, greater than or equal to 10 points for an individual patient with regard to the cumulative worsening score, the aggregate improvement score, then that is also judged to be clinically important. And in the Avacopan group, these are how they reported their data in table 2. Again, the GTI was used as the most important secondary endpoint for efficacy, not just safety, but also efficacy. Cumulative worsening score and the aggregate improvement score shown here with results at both 13 weeks and at 26 weeks for both the cumulative worsening score and the aggregate improvement score. The scores were lower, were greater than or equal to 10 points lower in the new treatment Avacopan group compared to standard of care, demonstrating that not only were these scores statistically significant, they were clinically important as well. Some additional thoughts about the construct validity. The consistency across domains of the GTI really reinforces this construct validity. So if one looks here on the left at the differences between the two groups in body mass index and at glucose tolerance as early as 13 weeks, and then across these other domains, very clear differences in lipid metabolism, steroid myopathy, skin toxicity, neuropsychiatric toxicity, and infections, favoring the new treatment group and really supporting the construct validity of the overall GTI. And then if one looks at the aggregate improvement scores, again, calculated from the same data set, you see that not only are there important differences in terms of less steroid toxicity in body mass index, lipid metabolism, steroid myopathy, and infections, there are also several domains, glucose tolerance, skin toxicity, and neuropsychiatric toxicity, where the patients actually had improvements over their baseline toxicity. And 70% of the patients in that trial were veterans of steroids. So they brought a lot of steroid toxicity to the trial, underscoring the importance of both of these scores in capturing the nuances of steroid toxicity. Continuing further on the construct validity idea, the investigators compared the GTI to a group of commonly known steroid toxicities grouped according to cardiovascular, dermatological, endocrine, GI, etc. And over in the right-hand column, you can see again the negative numbers illustrate the reduction in these well-known steroid toxicities that occurred over the course of the trial. And the differences between groups were mainly because of lower numbers of adverse events related to weight, which of course relates to BMI, insomnia, hyperlipidemia, adrenal insufficiency, blood glucose, and irritability, all of which are captured by the GTI. Like it is for most diseases treated with steroids chronically. And you can see here there was no difference between groups, but both groups were well below ideal health, shown by the horizontal dotted line here. And over time, over the course of the trial, substantial differences emerged with the new treatment. And I posit that these changes were due not only to the new drug, but also to reduced quantities of glucocorticoids over time. So the differences were quite stark for both the physical component score, or PCS, of the SF-36, and also the mental component score, or MCS, shown here. And also for another quality of life measure, another PROM, the EuroQual. Striking differences at both 26 weeks and at 52 weeks. So I'm going to pass now to Martha, who will talk about how to access the GTI.
Okay, I'll jump in here with video too. Wave to everybody. We're very eager to have the GTI used. That's where it can be most helpful to the world, and there are a number of ways to do that. Using the GTI requires a license, a use license, and we can make that available in 3 different ways. The analog GTI, which is the original pen and paper version. It's a DIY solution. Your statisticians, your team, using probably paper and some ECRF solutions to derive your scores. In addition to that, though, our team can help by providing you an option to bulk upload the data at the end of your trial so that you can have confidence that the internal team that you're using has in fact gotten the scores right. We can move also to the digital platform, which is a Part 11 enabled solution. I think that's on the slide as well. We can onboard and you could have access this afternoon. However, for a trial of any complexity, you'll want some custom integration via APIs. Dr. Stone referred to it earlier in the talk, where a lot of the data from the non-physician components that are always part of a trial, those can be actually integrated electronically so that they can flow into the GTI, get the 3 modules that the physician needs to enter, and then produce the scores. And finally, though it's not on the slide, is the enterprise version of the license. All these will customize based on the design of the trial, the number of patients, et cetera. But for companies who are interested in putting steroid sparing into their TPP, some are asking for an enterprise-wide license so that they can begin to use the GTI across many disease indications. So however we can make this available to you, we will certainly be delighted to do. And I think that's it for me, Dr. Stone.
Thank you very much for joining.